Thanks for everybody for being here. Again, I'm Jacob Bosley. I'm one of the hand surgeons at Desert Orthopedics. I just wanted to take an opportunity to talk to people about some of the things that I see commonly in my practice and give everybody a little bit more education, a little bit about hand surgery just in general. And then we'll go over some of the common problems. And then at the end, we'll have time for questions if people would like to submit their questions. So part of what we're going to talk about is anatomy. Anatomy is key to hand surgery itself. Another important thing I'd like to highlight is that in hand surgery, we have some sort of unique options that aren't available for a lot of other surgeries where we don't have to have a full anesthetic. Through the whole course of the talk, we're going to talk about what we can do for different problems in the hand, both operatively as well as non-operatively. A little bit about me. I'm originally from Ohio. I did my education in the Midwest. After enough time in the cold, my wife said, no more cold. And we originally went to North Carolina. We were there for 6 years, and we've now been in the Coachella Valley for coming up on 7 years. This is my crew here who love to go to the beach. I always think that part of the problem, part of the challenge with doctors and patients is making sure we're all speaking the same language. I thought this cartoon kind of sums up some of the problems that we have, where sometimes we think we've done a good job and the person on the other end isn't sure that they got what they were expecting, or we didn't set the expectations correctly. And so I think part of my job is to be able to make sure that I translate everything that we're talking about into something that we can both understand, as well as set expectations of not just understanding the problem, but also understanding what to expect down the road as we go through the treatment or as we go through the operative course. Hand surgery is very intricate, and as you get more and more into the detail, there is a ton of detail to be known about it. We could have an hour-long lecture series just about problems that you can have with your fingernails. I won't bore you with that today, but there are lots of sort of strange, weird anomalies and different things that can happen in hand surgery. It's my job to know those, and then, like I said, to discuss them and make it in such a way that everybody can understand. Again, anatomy is key to the hand. That's part of what really drew me into hand surgery. It has this very intricate, delicate anatomy. It really helps you think about all the engineering, so to speak, that goes into it, why it works as well as it does, and then also understanding what happens when something goes wrong, whether it's that something's broken or something becomes arthritic, what goes wrong and what are the sort of downstream effects of that. Understanding the bony anatomy is important, but especially I think within orthopedics, hand surgery is one where we really have to know all the soft tissue as well, whether it's how the tendons are working, how the nerves are working, the course of those nerves and those tendons. In surgery, I see all of these things, and that's one of what drew me to hand surgery in particular, is you know the anatomy and you see the anatomy firsthand. And I'll give an example of one of the surgeries for that. So our first common diagnosis, and if there's one to know for sure, it's carpal tunnel. Carpal tunnel is an extremely common problem within the hand. It's the most common surgery that's done within orthopedic surgery. So we'll start off with the simple thing of what is the carpal tunnel? I get it very frequently where people say, oh, I think this is my carpal tunnel. And it's just that someone told them that, or that it's a common thing in the hand, so it frequently gets thrown out as a problem that may give you issues with your hands. The carpal tunnel actually is a tunnel. This is looking at somebody's wrist in cross section. The bottom of the wrist are 8 little bones called the carpal bones. The top of it is a ligament that connects between those bones. So it actually creates this tunnel. Going through this tunnel are the 9 tendons that flex your fingers, and the tendon that flexes your thumb, as well as the median nerve, which they're showing right here. If the tendons get squeezed, they still keep working. The tendons are very much like ropes. The median nerve is much more sensitive. It's more like a hose, and the fact that if you pinch it, it affects the outcome rather than it being water that coming out the end. It's the sensation as well as the nerve function coming out into your hand. So I tell people carpal tunnel, everybody here in California knows about traffic. Carpal tunnel is sort of the bottleneck of where things are coming from your forearm to go out into your hand, and they bottleneck as they go through this carpal tunnel that's at the base of your palm. And again, the tendons seem to deal well with that bottleneck pretty well. The nerve, if it starts to get pinched, is pretty sensitive to being pinched. The classic presentation for carpal tunnel syndrome is numbness and tingling in the first three fingers, the thumb, the index, and the long finger. Technically, as is shown in the picture, it's half of your ring finger. It's very common that people are more bothered by carpal tunnel syndrome symptoms at night. People will say, I do A-OK through the day. It starts waking me up at night, or I can sleep for a couple hours and I wake up and I have this tingle in my hand. And sometimes people say they have to shake it out, which is what's called the shake sign. People notice that they're dropping things. Hey, I go to pick a quarter out of my pocket. I can't tell if I have a quarter or a nickel, or I'm going to pick up my coffee cup and I just dropped it because I didn't get the sense of how hard I was gripping it. Also, driving, particularly for a long distance, bothers people. It's the vibration of the road within the steering column within the wheel that aggravates the nerve and gives people more numbness into their hand. Despite the classic presentation, it's very common that people say, very rarely do people say, well, it's these three fingers and half of my ring finger. People say, yeah, it's my whole hand. My fingers are numb. My whole hand is numb. It's also very well described that it can give people pain coming up their arm all the way up to the level of their shoulder. When I see people for carpal tunnel syndrome, the first thing I do for any diagnosis really is looking at their hand. Just what do I see when I look at their hand? And having looked at thousands and thousands of hands, you start to notice the difference. The thing for carpal tunnel is people will start to have atrophy or the loss of muscle here at the base of their thumb. That median nerve, the carpal tunnel nerve, not only does it give sensation to those first three fingers, but there's also a branch of that nerve that comes back to innervate three little muscles here at the base of the palm or at the base of the thumb. If the signal is so affected that not only are you getting numbness, but it's also affecting or slowing the nerve signals coming to those three muscles, you can start to have atrophy or loss of those muscles. And then it starts to look hollowed out as it does in this picture. Another nice thing in hand surgery is we have two hands, so that I can always put your hands side to side. And that makes it much more obvious to see some of the asymmetry. If somebody has something that's asymmetrical, whether it's atrophy like this in the hand, or whether it's swelling of the tendons for a different diagnosis. We also have our variety of different things that we can do, provocative maneuvers, which we'll talk about in a second, that we can do to try to elicit those symptoms to see if we can figure out exactly where the nerve is getting pinched. And then if we need to, there's a study called an EMG, which looks at the function of those nerves, sending electrical signal down the nerve to look at how the nerve signal is conducted over a length of the nerve segment to see if there's a spot that the nerve is dysfunctional or if it looks like where the nerve is getting pinched. One of the provocative tests is shown here. It's called Durkin's compression test. It's squeezing on the nerve at the level of the wrist to see if it worsens the numbness into your hand. If the nerve is already getting pinched within the carpal tunnel and we compress it a little bit more, it'll exacerbate those symptoms. This is an example of the nerve study that we're talking about, the EMG. These are most commonly done by physical medicine and rehabilitation doctors, as well as neurologists, where we're sending signal down the nerve to see how it is received downstream. For carpal tunnel in particular, we're looking to see that the nerve is slowed as it goes across the wrist. Another very common question that we encounter is, well, why? Why did I get carpal tunnel? Historically, we used to tell people that it was because of typing. I think this was as typing was becoming a bigger and bigger thing. When they've done occupational studies looking at it, they found that wasn't really the case, that it's not really related to typing. As we sort of talked about with driving, vibration stuff is the worst. The worst occupation is running a jackhammer. But even with that, why does it happen? Most commonly, it's idiopathic, which means oftentimes we don't know. It just happens. It's something that happens through the course of life. It's something that happens if there's anything that's in that canal that takes up more space. It swells, and any pinch on the nerve is picked up as that numbness in the hand. Things that we do that are non-operative. The first step is oftentimes just wearing a brace. A lot of us sleep with our wrist curled up when we're at night, or our wrist extended. That position of the wrist pinches the nerve in the palm and can exacerbate or worsen those symptoms of numbness and tingling into the hand. One of the studies that showed this is what the picture showing here is. They took medical students, luckily it was done well before I got to med school, but they put pressure transducers into their palm and checked what the pressure was in the wrist in different positions, and they found that extreme of extension of the wrist or extreme of flexion of the wrist was bad for the nerve. The last picture here is showing a cortisone injection going into the wrist. This can be a very effective non-operative way of treating carpal tunnel with cortisone injection into the carpal tunnel. We can oftentimes help with that numbness and tingling, and most importantly, help resolve the waking symptoms. It's temporary, but it can help for months. It's about 1/3 of people who get a year's worth of relief from a carpal tunnel injection with cortisone. So getting down into the operative management when things have failed with non-operative management, proceeding to surgery. Again, kind of walking through the history. One of the older surgeons, when I first started training, his carpal tunnel incision was something more like this, where they were releasing that ligament well into the volar forearm fascia, which is part of what covers tendons in your forearm, as well as extending it all the way up into your palm. Over time, that incision has gotten smaller and smaller as we become more adept at releasing that ligament to make more room in there for the nerve. People are now doing what they call a mini open, which is a smaller incision within the palm, more like this, but still releasing the entirety of that nerve, which is enough to get rid of the symptoms. Me personally, one of the things that I was trained in and that I think is a really big difference is doing it endoscopically. In orthopedic surgery in general, we've just gotten less and less invasive, or figuring out how we can do the same work through smaller incisions and still do it in a safe manner. This picture shows the exact instrument that I do. It looks like sort of a pistol grip. It has an instrument attached to it with a light at the end. The orange picture here in the palm is a light at the end of the camera that's lighting up into the carpal tunnel. So we're inserting the camera into the carpal tunnel. It allows us to see everything that we're going to cut before we cut it. And it's all done through this small incision. It's less than 1/2 inch transverse incision at the wrist. And that incision ultimately ends up hiding well in the wrist crease. And I'll show you an example of that here in just a second. This is a video of one of the carpal tunnels that I did. So this is after we've made that incision at the wrist. We've sent a dilator up into the carpal tunnel to make sure that there's space in there for the camera. We also debride on the underside of the ligament. The ligament in the picture here is the white fibers going from left to right. That's the top of that tunnel that we were talking about. And once we've done that preparation, we can send the camera into the carpal tunnel. And through the video here, I'll show you what we do in a typical carpal tunnel release. So we're advancing from the palm out, from the base of the palm out into the mid aspect of the palm. It allows us to see the median nerve itself. This is before we've cut anything other than the skin to stick the camera into the carpal tunnel. We'll clear the camera to make sure that we have a good view. We see the nerve to make sure that it's protected and know where it is. We see that we advance all the way to the far end of the ligament to make sure we release that entire top. And then the blade is deployed here in the center aspect of the camera. And it's starting to cut that ligament. And we'll take multiple small passes through that ligament so that we're cutting just the ligament itself. We always start with a distal release for this. I do mine through a single incision at the wrist. There are ones that you do through 2 incisions. And I'll make multiple passes to make sure that we've released all the layers of that ligament, but nothing above it. The whole time the nerve is protected, it's off to the right side of the screen. The distal release of this is the most important. The mistake people make is not going far enough in to see that distal release. Usually when I do these, I'm also taking pictures. Here I took a video, but we'll also take pictures that I can show people the kind of before and after. Right away when we do a carpal tunnel release, there's more room in there for the nerve, but I tell people it takes a while for the nerve to recover. Usually the first thing that goes away for people is the waking symptoms. Here's a picture of what is after our carpal tunnel release is done. Let me back up on this. So here it's showing that above that ligament, there are muscle. Muscle is this reddish pink. We're avoiding cutting that muscle. We're also avoiding doing an incision right in the base of your palm. That's where we grip things. That's also where you put your hand down to push up from a couch or from a table. After surgery, a very simple dressing. Right away, your fingers are free. You're just wrapped in this ACE bandage. Or it's gonna be wrapped in a little compressive bandage to keep the incision covered, and that's just for 4 days. That small incision is completely waterproof by 4 days, and I let people get it wet in the shower at that time. I give a lifting restriction of nothing heavier than 5 pounds for the first 10 days, and I try to get you back doing your normal things, usually between 2 and 3 weeks. This is the finished product here. It's just this small incision at the wrist. When they looked at this in studies, it gets you back to work faster. It gets you back to your normal activities faster in comparison to that open incision, in particular the mini open within the palm. There's also good studies. This is one that was written by one of my fellowship mentors, Dr. Benson, sharing that it's actually safer. There's less complications. There's lower infection with doing the carpal tunnel release endoscopically or with the camera. It's also very cosmetic. This is a fairly fresh incision. The scar changes over the course of several months after surgery, but it gets to the point where really that scar is very, very difficult to see, even for me, who I make them all the time. This is an example of one of the hand surgeries where we have lots of options of what we can do for the anesthetic. I think a lot of people, anesthesia or how they're put to sleep for the procedure is one of their main concerns. General anesthesia is always what people think of as where they put you to sleep, as in the picture. Breathing tube goes down your throat. It's not that common that I do that. It's extremely uncommon that I do that for carpal tunnel syndrome. For carpal tunnel releases. This is how I do many of them is local injection with sedation. The sedation that's usually given is propofol, which one is the classic drug that's given for colonoscopy, where you're just in a twilight sedation. You don't know anything about the procedure. You're breathing on your own the whole time, but you don't know anything about the operation itself. Not for carpal tunnel syndrome, but for other procedures, I actually have people open and close their fingers. If it's something where we're repairing a tendon or something where we want to see it move, it's really nice that we can have the patient actually sort of go live action and moving their fingers, so that we can test our repair before we close up. Which is one of the really nice things with this sedation method. Another thing that we do for carpal tunnel, and even more so for trigger fingers, which we'll talk about later, is wide awake anesthesia. This can be done as completely as a local, meaning that they're only numbing it up with lidocaine. So I tell people it's very much like having a tooth worked on at the dentist, where they're numbing you up with Novocaine. This is a very safe, very easy procedure. This is done. This is Dr. Lalonde, who's a hand surgeon out of Canada, who in part got sick of waiting on anesthesia and figured out more and more what he could do with just his own anesthetic, with just doing local anesthetic, and has been very successful and has written several books and papers about all the different things that you can do under local anesthetic. And this is kind of one of the newer pushes within hand surgery itself. When you do it with anesthetic only, one, there's less cost. There's no groggy hangover. You can actually drive yourself home after a local anesthetic. You don't have to have any pre-op labs or pre-op EKG. It is nice to be able to see the active motion by the patients, if you want to test any of your repairs. And we're doing more hand surgery in this manner. Second, and a very common diagnosis here, especially in the Coachella Valley, is basilar thumb arthritis. This is arthritis that occurs at the base of your thumb. I tell people that the thumb is the workhorse of the hand. With everything that we do with our hand, we almost always including the thumb. The thumb works as a lever arm when we pinch and when we grip. So every ounce of pressure that you're applying out at the tip of your thumb, the joint down here at the base of your thumb sees about 12 or 13 times those same forces. Over time, that causes that joint to wear out. Of all the little joints that are in the hand, the base of the thumb here, the carpal metacarpal joint or the CMC joint, is by far the most common to give people symptomatic arthritis. Far more common in females than in males, although it does still occur in males. As we know with all arthritis, it's partly done by your environment, but also your genetics is a major component for that. It gives people a very predictable sort of deformity or visible change at the base of the thumb that oftentimes we can often see it without even getting an x-ray. I can tell people if they have arthritis at the base of their thumb. And just based on history, oftentimes we can also tell that people say, hey, it's really hard for me to open a bottle, open in a jar, very difficult. Turning the key in my car is hard, or even simple things like buttoning your shirt, pulling up your zipper on your pants, things that we do every day. This is something that you've done thousands and thousands of times. It just causes that joint to wear out over time. Non-operative things that we can do for this, there's a whole variety of different braces that can be worn for the base of the thumb to help stabilize and decrease mobility at that joint. One of the things that I talk to people about is holding a pencil can even be very painful. People say signing a check or signing my bills or any paperwork, it's really painful for me just to hold the pen. This is a little foam attachment that you can put on your pen to make it fatter. I started using this myself because I was amazed at how much it changes how it feels and how much it makes it easier and how your thumb feels at the end of the day. This is a jar opener, easily applied onto the top of spaghetti jars and things for opening it with just use of your fingers. I also get a lot of people that tell me they just hand it to their husband and ask their husband to open it, which is kind of what my wife does. Surgery for this always sounds a little bit odd in a way. I think people are used to, hey, I got my hip arthritis, I got my hip replaced, I got my knee arthritis, I got my knee replaced, I had shoulder arthritis, I had my shoulder replaced. Replacements for the base of the thumb really don't exist. This idea of the trapeziectomy is that we take out the arthritic bone at the base of your thumb. This small bone here is called the trapezium. The pain of arthritis here is these two bones rubbing against each other, and we take that trapezium out, and there's dozens of different things that are described. Most of the original descriptions are that you put a tendon in the place of that bone that you've taken out. And for many years, I did that exact operation. I do this incision, what's called a Wagner incision, at the base of the thumb. You take out that bone, and then this is showing harvesting of one of the tendons from your forearm that you then put in the place of that trapeziectomy. So historically, that was 5 or 6 weeks in a cast, another 6 weeks or so within a brace. This is an operation that's kind of constantly evolving, and part of my job is also staying up to date on what's the sort of latest and greatest and what have we improved. And then it's also my job to assess whether those improvements are lateral moves or are they really improvements. So this is the way that I currently do it, is with what's called a fiber lock. Instead of taking your tendon, I'm taking a non-dissolvable suture, and it's anchored into the base of the index metacarpal, or this bone on your index finger. And then it creates this sling to hold up the rest of your thumb. So our goal after surgery is that your thumb looks sort of like in this x-ray, where this is the thumb and it's kind of floating in space. This space here is supported by that non-dissolvable suture. One of the things that I like about this is it's less dissection. We don't have to make any incisions up your forearm to take the tendon out. The thing I probably like the best is that the suture is very reliable. One of the differences between people is they have different flexibilities. Their tendons can be very different. Every time that I put this suture in, the suture is essentially the same every time. So we're testing that, and that creates our suspension, that creates the stability for your thumb. It means less dissection. It also means less time of immobilization. I'm usually immobilizing people for about 3.5 weeks in a cast, followed by conversion to the brace and getting people in therapy. Another thing that we'll talk about, or we talk about through the course of this lecture, is that the less time we can immobilize you is really what we're looking for. The hand is very prone to stiffness. The more we keep you moving, the less we let that stiffness set in. Our third diagnosis here is hand and wrist fractures. Something we see a lot of. I tell people your hand is your way of interacting with the world, and that means that they end up getting in trouble a lot. Not often something that people sort of planned or intended to do, but something that we see a lot, and when people need it, you need it taken care of and relatively quickly. So I see a lot of people in the emergency room. I see a lot of people in my clinic after they've had injury. These are something that you get while you're being active, whether it's getting into an argument, or whether it's playing sports, or whether it's that you just suffered a slip and fall in the kitchen. Again, sort of going through the history, when people had breaks, one of the things we very commonly have done, and this has been around for decades and decades, is K-wires. These are little stainless steel wires that we can put in percutaneous, meaning no incision. We can put them down into the bone to correct that alignment. That are left sticking out of the skin. For metacarpal fractures in particular, they're usually removed around 4 weeks after the body's had time to fill in those breaks in the bone and put it back into alignment. We also do where we make small incisions and put screws, also to realign those bones. And if it's a really bad fracture, we can do plate, a bigger incision, more dissection, but we can get more stability with a plate. Hard part with this is the hand is fairly unforgiving. Hand is also pretty thin, unlike other places like in the thigh or in the tibia. You can put hardware in there and cover it, and it really goes unnoticed. Most of the time people don't notice the plates. However, in the hand, almost everybody feels these plates. It also, the bone and the tendon run right on top of one another. So if I'm also putting a plate in there, it gives something for the tendon to scar down to, and that's going to affect the mobility and the function of our fingers, and let the tendon scar down onto it. So it's especially true as we get out into the fingers. And then, of course, with a big dissection, the more fingers that you have injured, the more dissection you're doing, the more you're going to disrupt things in the hand and cause it to want to swell more. So relatively recently for hand surgery, they started looking at what other people were doing. This is an x-ray of a hip fracture. We see lots and lots of those here in the Coachella Valley as well. Vast majority of these are treated with what's called intramedullary fixation. We put a rod that sticks down inside of the bone to give stability. It's important to give that stability because it allows people to walk on it right away, allows them to put their weight and to get up and get moving on that rod. And people started coming up with a similar technology for the hand. Instead of putting into those K-wires that are sticking out of the skin, we found that we could put these are called headless compression screws. It's essentially a titanium screw without a top on it that we can put down into the bone. It sits entirely within the bone, so there's nothing that can scar down to. There's nothing to scar down to. By being inside of the bone, it gives us instant stability and allows us to get those fingers moving faster. When I do this, I usually do it with no immobilization at all. This is the incision for it, where we put in that screw down. This is just a soft dressing to cover up the incision and allow time to heal. But right away, people are getting their fingers moving. As we started getting more and more comfortable with this, we started using it for more complex fractures, meaning more pieces to the fracture. We started doing it for when there were more fractures, especially this, where somebody has broken all their fingers and their thumb. It's a lot of dissection to do plates and screws. With this percutaneously putting in these headless compression screws, instant stability, less dissection, faster motion. And then now we've expanded into doing it more, especially out into the fingers, what are called phalanx fractures. These, I think, can be problematic here in the desert, because a lot of people have arthritis in their fingers. And if we're having a fracture, we have arthritis, and then we're immobilizing them, they make for very stiff fingers. Where with these screws, we're getting people moving faster, again, to get you back to your activities faster, as well as not let stiffness and swelling set in. And we've expanded into this as we've gotten smaller screws. They can be used for more complex fractures, like this is a metacarpal head fracture that I had. A complex fracture, plate and screws doesn't do very well for this, but this is hardware that was all hidden within inside the bone and gave them faster mobility. We have a number of other tricks that we can do where we're trying to get smaller fixation to give us good stability. This is somebody that dislocated their finger, the joint popped out of the socket, and they broke off a piece of bone in doing that. With just this very small little plate and a single screw, when we understand the mechanics that goes into that fracture, we can restore stability and get people moving their fingers faster. Moving on to wrist fractures, which is an especially big problem, I think, throughout the country, but we see a lot of them here. This is the typical thing: is this a fall and you catch yourself. You reflexively stick your hand out to catch yourself, to brace yourself so you're not hitting your head. You injure your wrist instead of hitting your face. And it's very common that people have this, they'll extend the wrist and it essentially looks bent backwards, or what they call the dinner fork deformity. Tell people here in Coachella Valley, seems like we're getting more and more pickleball players, and then we get a lot of people that have broken the wrist. I think it's great for people to be out, being active. This is one where we're seeing a lot of wrist fractures from it, and there's been more talk about in the orthopedic literature, even that this is a growing trend, as well as it's causing some people some injury. When I was making up my talk, I especially like this guy on the right, who reminded me of my dad. He's got the pickleball paddle, he's got the pickleball gloves, he's got the pickleball. No need for gym shorts, no need for a t-shirt. He's just going out there in his jeans and in his shirt he might have worn to church. When we look at wrist fractures, looking at the x-rays, we're looking to see how displaced is it? What's the original, or what's the change in the position from the normal anatomy to where they are now? Is this something that we can treat non-operatively, or is it something that the alignment is going to lead to problems down the road that we need to have fixed? Non-operative treatment for this is usually 5 weeks in a short arm cast. This is a fiberglass cast like you think about kids wearing. We leave the fingers free. Even when you break your wrist, it's going to want to swell and stiffen up out into your fingers. So we get those moving right away. We're monitoring the alignment on serial x-rays to see that that alignment is staying in position. It ends up being that about a third of people will lose their alignment of the wrist fracture over time. So we monitor it with serial x-rays, especially within the first 10 days to 14 days of the injury. Historically, we used to do this called an external fixator, which were percutaneous pins placed into your wrist and in your forearm. It's gotten to the point where we're hardly ever using these anymore unless it's a really, really bad trauma. Now we've gone to using what's called a volar plate. It's an internal plate and screws that sits flush against the bone. This is an example of one. It restores the alignment. It gives you internal fixation, so nothing's sticking out. And then instead of moving people at 5 weeks, instead this plate is strong enough that we can get you moving usually within 5 to 10 days of surgery, so that we get, again, moving that to never let your wrist get stiff. Volar plate has really completely changed how we do these. I do over 100 of these a year. I do maybe one X-Fix every 1 or 2 years. This has completely changed it. I like that idea of getting people back to motion quicker. It also gives you more control of the pieces of those fractures so that we can get back better alignment. Better alignment leads back to better mobility. This is a lady, unfortunately, I took care of both of her wrist fractures because she broke this one and then a few months later fell and broke the other side, but easily got back moving and moving quickly. So just talking about fractures of the hand and wrist in general, swelling and stiffness, I always tell people those are like my nemesis. Every fracture leads to swelling and stiffness. Our goal is to restore the mobility and provide provide a quick return to motion, and also being cognizant of those soft tissue issues, not just focusing on the break of the bone. I try to get to them quickly so I can get you back onto the road recovery quickly. Fourth diagnosis here is one that's also very common within the valley, is Dupuytren's disease, or it's also called Viking's disease. I see a lot of this partly because a lot of it gets funneled to me as a hand surgeon, but I've been out at the grocery store and seen people and told my wife, like, hey, that guy over there's got Dupuytren's disease, and she probably just shrugs it off. But we see a lot of this. It's a painless contracture that can happen most commonly to the ring and small fingers. And it's thought to, they also call it Viking's disease because it's thought to tie back to like Norwegian ancestry. There's a huge history of this going back hundreds of years. People even talked about operating on this back into the 1830s. But to release the cord and give people more mobility, there's a definite genetic component to this that we know it runs in families, but it's not necessarily everybody within a family. It can hit 2 or 3 people within one generation and then skip 2 generations or sometimes more. It usually starts as this little nodule within the palm that people feel a very hard spot within their palm that they say they don't remember doing anything, or they don't remember anything that sort of got punctured there. But they'll develop this, and then over time it can grow. Less commonly, people have this little pit, or it looks like kind of like an indentation within the palm. And over time, those can grow into what the more common presentation is these Dupuytren's cords. These will feel like a guitar string almost coming up and down the finger, and slowly over time, usually several years, can cause the finger to draw down and limit people's ability to get their hand out straight. Treatments for this are really three options. There's surgical excision, which again goes back well over 100 years. Taking that cord out, if you take that cord or that abnormal tissue out, it allows people to extend their fingers. It's a very delicate surgery, which is what's shown in the picture here. The cord is this material here. What the blue arrow and these little red ties are showing is the nerve that gives sensation to the finger, and the cord can be very intricate or very closely approximated to one another. The second option for this is what's called a needle aponeurotomy. They're taking the edge of a needle and they're percutaneously putting it into this cord to weaken that cord to the point that they can pop it and bring your finger out straight. I didn't train in that, but it is an option that people do. Another non-operative management or a way of avoiding the operating room is what's called Xiaflex. Xiaflex is an injection that was designed specifically to dissolve this cord. It's an injection that's done in the office through usually 3 little pokes within the palm. I see you back 2 days later after it's had time to weaken that cord. We numb up your finger and then manipulate it to pull it back out straight. It's a little bit faster recovery. It gives people a non-operative way of treating this. This is a picture showing that needle aponeurotomy. This is a picture showing the Xiaflex injection. There are pluses and minuses, I think, to both surgery versus Xiaflex, and there are lots of papers out there comparing the two. Even in patients that have had both, I hear sort of both sides of whether they preferred the surgery or whether they preferred the injection. Regardless of how we treat this, whether it's surgery, Xiaflex, or even the needle aponeurotomy, this is driven by people's genetics, so there's always a risk of it coming back, and that's one of the things that we monitor, is to see if any of the disease is coming back as people get further and further out from their treatment. So we'll finish here with another common diagnosis. Trigger finger is a very common diagnosis, probably secondary only to carpal tunnel. Especially when I was in North Carolina, it seemed like everybody, whether they were young or old, had a gun. People were kind of disappointed to figure out that trigger finger really has nothing to do with shooting a gun. It has more with the snapping of your finger. It goes by, the formal name is stenosing flexor tendinosynovitis, but it's the catching of the flexor tendon within the palm as it extends down into the finger. It's very common that people will say that they woke up one morning and their fingers sort of stuck down in this flexed position. It's the swelling of the tendon as it's going into a little tube or tunnel that runs down the finger. And when there's a mismatch between the size of that tendon and the size of the tube, it catches or snaps. Usually people can kind of think about it, and it can be pretty painful as it snaps out. I give the analogy, again, in orthopedics, we love things with cars. So it's a sort of a truck that's too big to go under the overpass. This is showing a swelling in that tendon that has occurred, and then it's stuck as it's trying to get out into that tube. Non-operative treatment for this, if we catch it early, we can do anti-inflammatories. Bracing is described for this, but again, as we sort of talked about with fingers, they don't like to be immobilized. I try not to do the bracing unless it's for a very short period of time. Most commonly, what we're doing in the office is injecting people for this. This is one of the few times where cortisone injections can be curative. We can get trigger fingers to go away forever with one injection. Usually the cure rate is quoted between 65 and 70% cure. When we do non-operative things and the triggering keeps recurring, then we progress to surgical management. This is one where I would say the vast majority of them I do under just a local. I really prefer to do this just as a local of numbing your hand up. We make this small incision within the palm. We release that ligament, and then I'll actually have you open and close your fingers on the table to make sure that there's no more of that sticking. If there is still some residual sticking, then it usually means that there's still part of that tube that needs to be released. We release everything so that before I put any stitches in, your triggering is all the way gone. This is also a pretty fast recovery, just 5 days of a bandage in place, 10 days of having stitches in your palm. Right away, we're moving those fingers again to make sure that we don't let anything get stiff. That really is the end of my talk. This is my crew right here. Again, we love the beach, and then my daughter also loves going and cooking with my wife. I think we have plenty of time here for questions. If people want to submit questions, or if you have other things, I'm more than welcome to come and see me in clinic. I see patients both here at the Rancho Mirage office, back by the Desert Cardiology building, as well as I see patients at the Arduous Center in La Quinta. I'd be happy to see you. Happy to take any of your questions. Thank you, everybody, for your time.
All right. Thanks so much, Dr. Bosley. Yeah, so feel free, if you want to open up your mic and ask a live question, please do so. Let's be respectful of each other, but let's, if you want to put it in the chat, I can relay those to the doctor as well. So feel free to ask a question.
Yeah. So the question was about carpal tunnel injection with cortisone. Yeah, we usually try to get you a minimum of 3 to 4 months between cortisone injections. Cortisone for carpal tunnel in particular can give you long-acting relief. It's not curative like it is for, or like it can be for triggering. But with carpal tunnel, it can give you months worth of relief, sometimes even as much as a year worth of relief. I tell people you can get them every a minimum of 4 months. My big thing for carpal tunnel is when it starts waking you up at night. Is one of my big cutoffs. If it's waking you up at night, or if you feel like, boy, it's numb every day, that's the time when we need to do something, whether it's adding the cortisone injection or potentially talking about surgery. I think that's a good cutoff for it, when to do it.
All right, other questions, feel free. I know one question that typically comes up, especially with any kind of surgery and that kind of stuff, is how do you work within the center, within the Desert Orthopedic, with pain and pain management? Do you work within a team? Is that something that is solely through you, or how does that work within the center?
A little bit of it depends upon the scenario. I do think that we're sort of fortunate in hand that a lot of our things, the pain resolves pretty quickly, especially for our surgeries. So many of them are being relatively small surgeries. I don't think it has nearly the level of pain that we get with hip and knee replacements in particular. I try to do the vast majority of my own pain management with pain medication. I think getting it moving early not only helps with the return of function to your hand, but I also think it helps to decrease it. I think elevation of your hand helps to decrease your pain and your swelling, as well as help with your mobility. And there are lots of studies showing that for our common procedures, carpal tunnel, trigger fingers, you're usually looking at needing pain medication for anywhere from maybe 3 days to maybe 5 days. Most commonly, people are taking it at night to help them sort of ease off to sleep. It's at the end of the day that it'll bother them more. So I try to manage it all within our own department, as well as trying to get you back to your sort of normal routine quickly and get you off of the pain medications before you have much in the way of side effects.
Great, thank you. That's very helpful. I see Bernadette, did you have a question?
Yes. Are there other causes for wrist pain besides fracture? Say, for instance, I do weight training and my wrist is pretty sore, but I'm not sure that I have a fracture.
So fractures themselves usually have one isolated trauma associated with them. The pain about the wrist, there are many different causes for it. So part of it is getting down to sort of what aggravates it. When did it start? And I tell people within the hand and within the wrist, every millimeter counts. So, just knowing exactly where it is and starting off with a good set of x-rays. Sometimes you can have arthritis in your wrist. You can have tendonitis within your wrist. You can have a pinched nerve that's bothering you. You can have injury to, there's a fibrocartilage that exists on the outside of your wrist that bothers people. Usually the first thing we start off with is getting x-rays and then walking you through your history of when did this start, what aggravates it, is it getting better, is it getting worse, and what other symptoms are associated with it.
Okay, thank you.
Sure.
Great question.
Sure.
What's a success rate if you have carpal tunnel?
So the question is for carpal tunnel, what's the success rate of the surgery? So it's, again, the most common surgery within orthopedics. And I think part of what got it there is that it's common, and part of what it is that it's a very successful surgery. The success rate, I think, is driven by a number of different things. The biggest thing that can give you numbness into your fingers can be a compressed nerve in your neck that gives you radiculopathy, or that can give you pain out into your arm. So we talked before about the carpal tunnel injection being something to give you relief, and to give you relief for months. It's also a tool for me that if I inject you, I usually see you back in 6 weeks, because I want to know that we got it better. But I'm also using that as a filter, that somebody wrote a very simple paper that says if we give you a carpal tunnel injection and you get better, if that comes back, you're much more likely to have success if we do the surgery, in comparison to somebody that we inject and it doesn't get better. So I'm using that as a filter to try to increase my success rate. It lets me know, hey, I think we're chasing the right thing. I tell people is the proof is in the pudding. We injected you right there. That got you better. That tells you we're chasing carpal tunnel. If I inject you and it doesn't get better, then I got to look to see, is it something that the nerve is compressed more proximally, or is this something that's compressed in your neck? Part of our practice is also people that are taking care of cervical spine issues. And that's usually what I'm looking at. Is it some cervical spine meeting in your neck, or is this in fact carpal tunnel? And so that's one of the major benefits to me with the injection. But like I said, it also benefits the patient as well. That's a good question.
All right, Bernadette, another question? I see.
Yeah, I have. It appears to me that I'll not only have trigger thumb, but also that intense pain point in the basilar, whatever it was that you described. Would it be that I have both, or would it be that the clicking in my thumb is causing the pain below my thumb?
So it can be both.
Oh.
The clicking sounds very much like trigger finger. And like I said, the nice thing with that is we can usually get that to go away with cortisone injection. The thing at the base of the thumb, again, most commonly aggravated with pinching and gripping. Sometimes for the thumb in particular, that's when your trigger thumb will bother you also. And sometimes we have to address both of them, or depends upon the scenario and how your x-rays would look. But oftentimes we'll say, well, trigger thumb is a 5-minute surgery. Let's do your trigger thumb. If we get you 80% of the way better and you can live with that, perfect. If we need to go to looking at your base of your thumb, that's a bigger surgery. It's a bigger recovery. But if that's your main problem, we can sort of stage that differently.
Thank you.
Sure.
All right, great questions. We have a few more minutes. If anyone else has a question, feel free to ask it. And in the interim, as I mentioned, this is recorded, and so it will be edited within the next 10 days. We'll have it online in a multitude of sources. And if you registered to our system, then I will send you out the link to our YouTube channel as well. And while you're thinking of the last final question, this Thursday, there was some confusion with an ad that we we had running, but we're moving back now that we have a little bit more space in the building. We are moving back a little bit to a combination in-person lectures as well as hybrid via Zoom. So you always have to look and see which it is. Not everyone will always be in person, but this Thursday, part of our Desert Orthopedic series will be the role of CBD in pain management, a modern approach to relief, with Dr. Bogosian, that we were just talking about pain. And that will be in person here at the Annenberg Center in Rancho Mirage, as well as on Zoom. So that was kind of the confusing thing this week. So if that is something of interest to you, please join us around 4:15. The lecture starts at 4:30 here in the Annenberg, and on Zoom as well. And then Bernadette, please, another question?
Yes, I wondered if you could tell me the first and last name of the physician that's speaking.
Oh, yeah. Dr. Bosley, if you...
I'm Jacob Bosley. Let me put it back up here to the beginning. The last name is B as in Bravo, Osley.
Great, thank you. I think that my husband and I probably both need to see you.
I have a number of husband teams that I take care of, so I'd be happy
Thank
to see
you.
Yeah, and you just call over to Desert Orthopedic. It'll be on our website as well as Google on any aspect of finding them, and then you can talk to them about scheduling an appointment and getting right in the system.
So the question is about return to golf after doing carpal tunnel surgery. So I usually tell people 2.5 to 3 weeks to getting back after it. I usually tell people the first time you go out at 2.5 weeks, just go hit a small bucket of balls and see how it feels just making contact with it. After it feels pretty good, hit a small bucket of balls, go play 3 or 4 holes, and then kind of working your way up to 9 and then eventually 18. But I think you'll be back to 18 probably within 4 weeks. The kind of nice thing with carpal tunnel release is it's not like a hernia repair. It's not like other surgeries where there's something that we're protecting. Really, the only thing that we're protecting and giving you that lifting restriction for the first 10 days is making sure the incision is healed. It heals pretty darn quickly because it's such a small incision. After that, what usually limits people is just that it's sore, the vibration of your club. The worst thing, of course, is hitting a root or taking a big hit out of the sand. It bothers people. But even if you said, well, I'm going to play it 2 weeks, no matter what, it's just going to cause you pain. It's not going to undo the surgery. So it's getting back, but I find most patients tell me 2.5 to 3 weeks.
All right, great question.
Also a common question.
All right, if there's no more questions from the audience, any last minute questions? All right. Then, as I mentioned, this will be edited and it'll be online and it'll be sent out to you. A multitude of ways you'll be receiving it. And Dr. Bosley, thank you again for your time, sir. I know it's been a long day, as always. And so thank you for your time tonight.
Thanks, everybody, for tuning in.
Thank you, everyone.